introduction, and thank you, Clarinet, for inviting me to give this talk. So you've already had an introduction because type 1 diabetes basically is autoimmune disease. There is a type of type 1 diabetes, idiopathic also. But in all of these, whether it's idiopathic or autoimmune, the treatment is finally insulin only. So today we will talk basically on what is insulin therapy in type 1 diabetes. How does insulin help? Where is the role of insulin? And how what type of insulins are available and what are the major regimes we use in treating of type 1 diabetes. So let's start. This first thing is most important to understand is the people, these two guys who got a Nobel Prize in 1923 for discovery and the use of insulin in the treatment of IDM. That time it was called as insulin-dependent diabetes mellitus, which we have now changed the terminology as type 1 user. We don't use anymore this terminology. So that was there in 1923. So this is the first, patient of December 15, 1922. There was a miracle which is there by using insulin. You can see the whole change in the body of this within 2 months, in fact. So within 2 months, the child was looking like a normal child, listening just with insulin. And here we're looking at caxic and maxic because of the loss of so much of fluids and, gastric acid body breaking up because of ketone formation and everything. So therefore, this is that miracle of insulin you can see. Now let's start with a case before we talk about the use of insulin type 1. This is a child of male 20 years old, 12 years old, who was admitted with polydipsia, polyuria, weight loss, and difficulty in his breathing. So he was breathing very fast. So he was treated for a decay, because we're not going to talk about decay here. We're going to talk about insulin type 1 with SPAT protocol. SPAT protocol means that he was hydrated. After hydration, he was started on insulin. Insulin is given 4 breakfast, before lunch, and before dinner in order to control the sugars. So once the decay was resolved, then he started taking little orally fluids and a little bit of diet. Then the question came, and now you have to shift into insulin. So this is where you start with insulin. Once you have many times you pick up patient on the decay, and then you have to change on to subcutaneous insulin. That means regular insulin has to be given. So now the plan is to shift to subcutaneous insulin. How to switch to subcutaneous insulin? Okay, that's your. So the transition to subcutaneous insulin from DKF, these are one group patient who come with DKF in return. There's another group patient who come to your OPD and they already are having high sugar, then you want to just start immediately without any complication, just that the sugars are picked up. Maybe the family history is there and they thought, or maybe the parents knew about it, that the child is passing a lot of years, so let's get a sugar checked up. And they get a check that's quite high, 344, and they come to you in the OPD. So these are two things. Now, this is the first scenario where you are going to transit to subcutaneous insulin. So insulin is the only treatment for type 1 diabetes. Okay. So you cannot, once a patient on DK is improving, you will continue with subcutaneous insulin drip till you will shift him onto subcutaneous insulin. So the insulin drip will go 0.5 unit per kg per hour, and then you will give up regular insulin. You will start 0.3 unit per kg. Then after 30 to 60 minutes, you will stop the infusion. And then again, you will continue rapid insulin, 0.3 unit per kg, then stop insulin after 10. So basically the difference is that there is regular insulin, there is rapid insulin. Regular insulin, you will stop insulin after 30 to 60 minutes, and rapid insulin, you will stop about 10 to 20 minutes after you have given the subcutaneous injection. Then according to the weight, according to the everything, you keep on calculating those and this. We'll talk about that in the next few slides. Now next question comes in, how do you calculate total daily dose of insulin? So if a child is like 0 to 5 years, like 6 months to 1 year, the target glucose is around 100 to 180. The total daily insulin is 0.6 to 0.7 per kg per day. The basal insulin requirement is 20-30%. So you have more boluses of insulin being given in the early childhood because you are taking more carbs. You need more boluses. Whereas a child grows older, like 5 to 12 years, your target glucose is 80 to 150. And your total daily dose is 0.7 to 1 unit per kg per day. And the basal insulin is 40 to 50% of the total insulin. And a child who is going in dollar sense, 12 to 18 years, his target glucose 80 to 130. The total daily insulin is 1 to 1.2. The basal insulin is 40 to 50% of the total dose. So you have a children in honeymoon period may need only 60 to 70% of the full replacement dose due to some basal beta cell function. So therefore, what is happening in this period is now you got to give some insulin, the sugar become better. So phase comes honeymoon period where the residual, the pancreas produces whatever residual insulin is there, it starts coming out. And you may not need that much insulin, you may be able to manage just with one long acting insulin during that time. So, so only 60 to 70% of the The replacement dose may only be needed because the residual beta cell function. And that's why extra insulin requirement becomes less. So this is basically, the dose, the calculation, the basal insulin requirement, and how much insulin you required per kg per day. Okay. So therefore, the weight will make a difference. If the child is 10 kgs and he's 10 kgs, maybe 1 year old. So you need around 0.6 into 10. So that means 6 units the whole day in total daily insulin. That makes a difference. Now, the insulin therapy, the goal of insulin therapy is to mimic physiological insulin secretion. So, sorry. So the goal of insulin therapy is to make physiological insulin secretion in response to blood glucose. So when the blood glucose rises, the insulin secretion comes in your own pancreas, and then sugars come low. So we want to do the same thing. That is the idea of insulin therapy. Now, insulin requirement, again the same thing. When during the recovery period or during honeymoon phase, it may be just 0.4, 0.3 unit per kg per day. And in the pre-pubertal children, 0.7 to 1 unit per kg. Post-pubertal children, after puberty, the requirement becomes increased. There's a lot of insulin resistance in the body which comes. So you need 1 to 1.5 unit per kg per day. So that's what the insulin requirement is changing according to age, as I showed you in the previous slide, and the same thing is happening here. Now, what are the available insulins we have with us at present in India? So in India, the scenario is that we have basal insulins, we have bolus insulins, and we have premix insulin. So the basal insulin, once you give it, you will give it, and then you will get a resting a basal insulin. You give it and act for a longer time, and there is less variability. That's that's the best basal. The lesser the variability, longer the duration of action, the more better the basal insulin. Then you have bolus insulin. Bolus is given just before the meals. So you have from the this normal bolus insulin being given. So the bolus insulin you are given it from the normal person. This blue line is for normal person. This red one is ultra fast acting insulin. Then there's a fast acting insulin, and then there is an insulin regular human insulin. So this is there. So therefore you have a fast acting insulin, you have a ultra fast acting, you have fast, then you have a regular human insulin. So therefore you can see these curves are different. So the ultra fast is almost similar to that of your normal pancreas, and the rapid is also like that. But when it comes to regular insulin, it is not, the peak is that much, and it acts for a longer duration. So the more chance of hypoglycemia. That is there. Then you have the premix insulin. So there's a mixed, both are there. Already you have parental and you have basal line in that element. So we'll talk about what are the premix insulin. And in this, what is happening is a parental component, you have a parental component, you have a basal component. So the parental component is trying to improve the sugars with whatever we're eating, and the basal component will act for longer time and keep the sugars in between the meals. Okay. So this is the basal insulin, as you can see here. Now coming on to the various types of insulins, the insulin, the onset and the peak and duration. Let's start with the rapid acting insulin. The rapid acting insulin is Lispro, Aspart, Glucine, and Fiaz. The onset is within 2 to 15 minutes. The peak is 30 to 90 minutes, and the duration is 4 hours. So you have, an onset just in 2 to 15 minutes. The peak is 30 to 90 minutes. Duration is 4 hours. So it acts for 4 hours on duration. So the peak is in 30 to 90 with the peak coming, and 4 hours, it's finishing off. So that's how rapid acting insulin is almost physiological to your own pancreas insulin secretion. Then you have a short acting regular insulin, onset in 30 to 60 minutes, peak 2 to 3 hours, duration around 6 to 8 hours. So that's why it's a little longer duration. But the problem is that you're going to have a later on, effect of there, and you may get more hypoglycemia. And because of that, you may have, your midday before lunch, you may be also, higher set. So intermittent acting NPH, onset is 1 to 3 hours, peak is 4 to 6 hours, and duration is 10 to 20 hours. Then you have the long acting insulin. So these are the insulin which are the basal insulin which you use. There's glargine, 100 unit, detamel, degludec, and glargine 300 I use. Togios, which is also called Togios. Degludec is called as Tresiba. So the onset of glargine is 2 to 4 hours, detamel is 1 to 2 hours, degludec is 0.5 to 1.4 hours. The glargine 300 is also, from 2 to 3 hours. So therefore, this is how the most important thing, there is no peak. It is long acting, except for detamel, there is a peak. around 6 to 12 hours. The duration is very less. It works for around 6 to 12 hours. And there's a slight peak in brain. Whereas in the duration of glargine is 24 hours, duration which acts, detamera is around 16, 24 hours, degluted 42 hours. So these are all long-acting insulins. So basically, you should remember that rapid-acting insulin 4 hours, short-acting regular insulin for 6 to 8 hours, NPH for 10 to 20 hours, this long-acting insulin 20, 24 hours. The longest-acting one they say is degluted tresiba is 42 hours. So then there's pre-mixed insulin. Many times, because of the resources and the limitation of resources and financial issues, you cannot use these analog insulin, these rapid acting. So what is being doing is we use pre-mixed insulin. Pre-mixed insulin may be a combination of regular insulin and NPH, 50-50, 30-70. Or you can use analog insulin. So analog insulin like Aspart 30-70, 50-50, Lispro. You have Rispro also. There it is 25-75 and 50-50. So you can use these combinations depending on the situation, individuals, the pocket, whether the pocket can afford the rapid acting insulin or not afford. So that makes a difference. The onset is, with the pre-mixed insulin, 30 to 60 minutes. With rapid acting insulin is within 5 to 15 minutes. So very, very fast acting, just like your, this rapid acting insulin is there. So therefore, this is there, and the peak is dual in this case, because you're using 2 insulins, and duration is 10 to 16 hours for all of them. So that's how it is. This is, your insulins, which is available in the Indian scenario, and these are the various types of insulins and the duration and the peak. Now coming on to the logistics. Now, when you use insulin, you have to be worried about a few things. The storage, where you want to store the insulin, where is the site of giving insulin, what is the technique of giving insulin, how are you going to dispose of needles and all, which are being used in insulin therapy. So these are some things which are commonly which come across the mind of everyone, every physician who wants to give insulin. So how these are some logistic one has to be careful of. So you have to learn about these things. We're going to talk about it now. The storage, as storage is concerned, it has to be stored in 2 to 8 degrees. It's a very common scenario. The patient will come to you, okay, I kept it outside for 2 hours, 3 hours. I think it's not my sugar coming high. They will not tell you. Then keep on asking him, अपने इंसुलिन अंदर वापस रखा नहीं सर, हम तो भूल गए, वो उन्होंने बाहर रख दिया, तो बाद में हम 6 घंटे अंदर रख दिया, तो ऐसे. So these are some reasons you must keep in mind that it can affect the potency, the efficacy of the drug. So insulin will not work maybe if you kept it for room for a long time. So it should never be frozen. There's a long mistake. Many patients, they take it at home and because they've not been taught by the physician or by the educator to keep it in the refrigerator 2 to 8, and they keep it in the freezer. Or they will tell the servant, isko fridge mein rakh do. The servant will keep it in the freezer thinking that is something, very, very specious, and he keeps it. So then after some time, after it gets frozen, once it is frozen, it's useless, you must throw it away. So if you have a non-availability of a refrigerator, pack insulin in a poly bag. Maybe you are still in a remote area or something. You do not have a refrigerator or electricity problems here. Pack the insulin in a poly bag, tie it with a rubber band, and put it in an earthen pot, half filled with water. So this will keep still some cool in there. So you must keep the insulin pen in a cool, dry place. Do not store when the needle is attached. So remove the needle and store the pen. Then always avoid extreme temperature. Do not keep the pen near the direct sunlight. Do not keep it in the park car. Do not keep it in the kitchen above television. Okay, and very, very important, discard the accidentally frozen insulin, or if the insulin is discarded, please discard it. So this is as far as the storage is concerned. Now these are the various ways you can store it. There's a refrigerator. You can see here is a poly bag. You can keep the insulin like this in here and put it into ice and then put it in the box like this. Or you can take this earthen pot and keep water inside, cold water, and then put the poly bag inside it. So that's all. So this is that matka we all talk about, and matka you can store it like this. So these are the various ways of storing and keeping this insulin. Now this is as far as storage is concerned. The site, where should you give the insulin? That's the next question. And anytime we are the patient don't know, and their patient are always they're confused. They're giving in the wrong sites wrong. The site is very important. The injection site, these are the various sites which you can use. This is the lateral aspect and the anterior aspect of the thigh, the right and the left thigh. You can use this. You can use the abdomen on this area, and just three fingers of the child on both the sides of the umbilicus, and then this area you can use for everything. And You can use the lateral, the triceps area of the arm, though there's very soft sculptural tissue you can get because it's also put in. And these are the areas which you can use. Now, the most important thing is once you use the area, you have to rotate the pen so that, both interside and intraside rotation is important to prevent lipohypertrophy. And you can use the buttocks also, the upper and outer part of the buttocks for giving basal insulin. So basically, what is the message is that intrasite rotation and intrasite rotation also. Very, very important to prevent lipohypertrophy. Very, very common, you will get your patient to come back to you with an insulin calm nahi kar raha. So then you'll tell him, insulin calm kaise nahi karega? So no, theek hai. So then you check for air bubble, there's no air bubble, then you keep on, then when you go and check the site, there are lumps and bumps. So therefore, what they have been doing is giving air same way. And very important thing to remember is a special thing that a child will always like to have the injection at the side of lipid because the neurons, the nerves, the fibers getting little down. So there is almost, like anesthesia there almost. So when you prick it, it does not have that much pain. So the other thing, if you're pricking a child, it does not come to pain. That means that area is not working. I mean, there is some lipohypertrophy audio. So this is another way of, detecting. So that's something which my message is there. So please, intraside rotation must be there. That's as far as side is concerned. The technique is also very, very important. Now, first of all, the incorrect side of injection side, the delivery devices are not good, and the technique may modify the insulin absorption. So you will have poor glycemic control. Okay, so that's important. So roll up play therapy, you can just take a Barbie doll and you can just inject on it and show where the patient, how it, or take any dummy device and just demonstrate where the injection have to be given, how it has to be given. That's very, very important. So the needle is around 4 mm to 6 mm, maximum 6 mm. The gauge of the needle is 30 to 32. So these are needles which are being used in various devices. So first of all, clean the local site, not necessarily clean the spirit. You can clean water also. It's because you're using the same pen for the same patient. There's no need to get worried, panic. Gently pinch up, as you can see, pinch up using a thumb and index finger. Push the needle through the skin. Push the plunger slowly. Count till 10 seconds before moving the needle. So you have pushed the plunger, you push him. So you given at 90 degrees, you can see here it's giving him here, and it's gone to the subcutaneous tissue. And we count till 10 seconds before moving the needle. So 1, 2, 3, 4, 5, 6, 8, 9, 10. And then you can remove the needle. And then after moving the needle, then count for 3 seconds and then release the pinch. So there is very less chance that you will be some of the insulin will be coming back, because what have most of the the patients, they will press and then they will leave it and then take out the pen. So when they do like that, 1 or 2 drops come out, it's a drop nikala. So this you have to tell them that you have to pick it up, give it 1 second, 10 seconds, count a second before removing the needle, remove the needle from the skin, and then count 3 seconds, and then release the pinch. So okay, and very, very do not massage the injection site. A lot of people, give injection and massage like that, and then you see the results. So there's not a good, this concept of doing a massage, right? So you must understand this. Now, coming on to, this was we talked about the insulin which is right. Now, there are many insulin which people are taking mixed split regime. So there you are getting regular insulin and NPH is there. So you can see here, this is active regular insulin, and this is NPH. The cloudy insulin, this is cloudy insulin, this is NPH. Now here you are having, you're having a regular insulin, and then you're having NPH. Now when you are giving this insulin, there can be a 40 IU, there can be 100 IU, therefore in that instance, 1 ml may contain 40 or may 100. So therefore you must be very sure that the syringe which you use is showing the same. So you can see here, this is mentioned here on this syringe, U40. So this is a 40 IU, 1 ml will have 40 IU. So therefore, what you do is first you take the regular insulin, then you take the NPH. So that, then you have a mixed, a split mixed split regime. So in the same way, you have this is a U100. So this syringe is containing 100 IUs per ml. So this is the difference. Okay, that's something. Now you can see here, how do you care? Can you see, can you appreciate this? This is a lipohypertrophic sites. This is where the insulin has regularly been given. Now it is not even for even adults who are taking insulin, is the same scenario. It's not that only children have this problem. Even adults who are having, taking insulin for it, and who are initially type to take basal, and then they need vasobolus later on. So they also get this lipohypertrophy. So lipohypertrophy, you have to care of the lipohypertrophy. So first, to regular review the site of, review of the site health. You have to keep on seeing the site. So whenever you give injection, just touch and rub and see what is the site like. Rotation in a manner, keep on rotating. So there's a 4 R's. Reuse of needles to be avoided. Do not use the needle again because they get blunt. And because that pain occurs, and many times there are more chances of getting hypertrophy because of the inflammation which is caused by that in the tissue. And revision of insulin dose when shifting from hypertrophy to non-hypertrophy. So if you shift from an area where there's hypertrophy to a site here where there's less, so you might have to adjust it. So because here what is happening is the parents are saying, sir, it's not working. So I've increased the dose from 5 to 7. Again, the lipohypertrophy side, it's not going. So when you will shift that 7 to normal site, your sugar will fall. So that's why you have to revise insulin dose when you shift from this. These are 4 R's one must keep in mind whenever beating with lipohypertension. Very, very common scenario, very, very common situation, especially in our kids in India, where they're getting insulin and this type of situation occurs. Okay, so we talked about storage, we talked about size, we talked about technique. Now, how do you dispose of these needles? That's important. Don't discard the sharps in garbage bins. Put sharps in any plastic container, cover the label it, like this is a household shop or whatever it is, and take it to any hospital or any other place where there's biomedical waste disposal facility. So you can do that. There are many doctors and many clinics, they have already facilities for biomedical waste. So they can just do it like that. That's the best way to dispose of these needles. So what are things to remember? I mean, for all the position, the right insulin, the right dose, the right time, and the right technique. So all makes a difference. So the right insulin, the right dose, the right time, right technique. These all make a difference. So now coming on to the various insulin regimes. We have talked about insulin, we talked about the basal insulin, we talked about the bolus insulin. Now we talked about the insulin regime. So one is the basal bolus regime, which we commonly use in most of our type 1 diabetes. So bolus is given every meal, breakfast, lunch, and dinner, and the basal is given, depending on if you use Levy, you might have twice a day. If you're using a longer acting one, so you might once a day. And then there's a split mix regime we just talked about in the previous, when we were talking about insulin serum U100 and U40. So pre-mix or mixing regular NPH. So these are the various regimes. Now let's see. Now what are we doing? What are the prescribing patterns in India? So that's also important to know. What are the prescribing patterns in India? So let's see the regime, the problem, and the recommendation. Okay. Now there are a lot of people who use only human insulin twice daily. So they just give regular insulin morning 5 unit, regular insulin 7 unit. So this is only then what happens is you are going to control the sugars in the meal, but the pre-meal sugars will be high as there is no basal. So therefore it is not recommended. Then twice daily pre-mix. So what is happening? You're giving pre-mix in the morning, pre-mix in the evening, and then pre-lunch will be hypos will be there because of the pre-mix insulin again. Lunch is uncovered, so pre-dinner high will be sugars. So therefore, this is also not recommended unless a special situation. Then pre-mix NPH plus short morning, evening with short acting at lunch. So immediate dose titration is not possible. So better sugar control than the above. So pre-mix NPH plus short morning, evening with short acting at lunch. Immediate dose titration is not possible. So better sugar control than above. Okay. So that's something which you must, must make remember this. Then you're mixing your breakfast, dinner, and you're giving a mixing at breakfast, you're giving a mixing at dinner and making it. Then short acting at lunch. Okay. So there's something different there. Previous one was pre-mix, already is mixed. Then you have mixing. So you have taken a little bit of regular insulin and you have taken the another, you have given a lunch and you have mixed it and given a break with that. So mixing is required. That's one recommendation. Yes, you can use it. Then basal long acting, glargine, detamere, togios, or degludec or tasiba, and mealtime boluses. Okay, so 4 pricks a day. Okay, that's important. So this is highly recommended. Then you have your very final is insulin pump. So insulin pump, only problem ketosis, but now with this knowledge of the new pumps, The chances are very, very less. So it's highly recommended for all type 1 diabetes insulin pump. The only factor is the cost and this thing. So therefore that is because our kids are becoming high tech these days. So kids like 6, 7, 8, 10, they know a lot about how to use these devices. So it's very easy for them to handle. So very, very important message. Twice a day's pre-mixed insulin for type 1 is totally unphysiological and illogical. So never use pre-mixed insulin in type 1 diabetes, especially taking it twice a day. And very commonly used in some with some doctors. So I think that tradition of there should be definite. So you can just see, if this one mother and one child, both of them tied, how can they ever run? So it's difficult. So it's very, very illogical. So if there are two children running, it'll be easier for them this thing. Because the footsteps will be different. This everything. So that's why using a twice day pre-insulin for type 1 both unphysiological and illogical. Now coming on to the basal, this thing therapy, basal bolus therapy. So you're getting 3 or more shots a day, more flexibility of lifestyle. You have only a normal lifestyle. So eat whatever you want and inject insulin as per the carb count. So whatever the carbs is there, you inject insulin. So if your carb ratio is coming out to 1:15, so every 15 carbs you have to take 1. So if you're taking 60 carbs, you take 4 insulins. So you eat what you want and then it's less nocturnal hypoglycemia, better glycemic control. And by this, you're ready to be prepared for the pump because the pump works on basal bolus method only. That's how the pump works. Then the another one is, where you're using a combination and they're using the rapid acting insulin before lunch and dinner, but in the morning, in order to cover school break means different time, you're using regular insulin. So regular insulin before breakfast, analog insulins before lunch and dinner, and then basal insulin cover once a day. So that's how it is, That's this thing. Okay. So this is there. And then, the next comes out is, so this is when you're in the school, how you manage in the school. This is a very common scenario where school children, they come and they say that in the school, when they come back to school, sugar 300, 350, 400. So this is the one way of doing it. Then another way of controlling the sugar is that maybe people have resources are less and you need to buy insulin which is cheaper. So what you can do is use regular insulin, in the morning and along with NPH. So this is you have a what happened. So there and you for the patient patient especially with a patient who cannot take afternoon insulin. To give a regular plus NPH in the morning, it'll work throughout, cover the lunch and dinner. And then you give a rapid acting insulin or a regular insulin in the dinner and one basal insulin which will act throughout the night. So this is another way of tackling, this patient. They are there. Then there is another split mix regime. So in the split mix regime, there's a pre-mix or analog insulin, mixing NPH with regular insulin in a syringe. One shot has 2 insulins. So what you are doing here is you have a pre-mix analog. Then you are mixing NPH with regular insulin in a syringe. So you mix both the two in a syringe and you're giving this thing. So when you give it, it covers up regular, it covers NPH. And the same way before dinner, you're giving, regular NPH. So you're trying to cover 24 hours with the help of, this insulin regular NPH. So this is called a split mix regime. So pre-mixed or an analog can be used. So mix NPH with regular insulin in a syringe. One shot has 2 insulins. So each will have its own peak at different times because there are 2 insulins. Okay. But the only thing you cannot give more than some. So fixed amount of carbohydrates at a fixed time. So if you're going to give regular insulin at 8, so 8:30 you have to give a fixed amount of carbohydrate at this step. Evening snack might need extra short. So even it takes an evening short minute. So there are lesser pricks, only in one lesser pricks. It is not very physiological. So this is split mix regime. Now then comes split mix. Another one is regular plus NPH at breakfast. So regular and NPH at breakfast. So you're giving regular insulin plus NPH at breakfast. So it's going to cover your breakfast. It's going to cover your lunch. It's going to cover this thing. But so at dinner time, again, you give regular insulin and NPH. So regular insulin at dinner and NPH at bedtime. So this is also another split mix. So you have made a split mix one. See, the previous split mix was you gave regular and NPH together and you gave regular and NPH together in the night. So you have given 2 shots and they work like this. So another way is that you give regular NPH at breakfast, regular insulin at dinner, and NPH instead bedtime. So to cover up the night. So these are all the spectrum. So this is all the various basal bolus split mix regime, using only regular insulins and then seeing what's happening. But out of all this, basal bolus is the best. And if the best is using an insulin pumps. Very, very good. It's best treatment method and very good result. So what is the choice of treatment? Intensive insulin therapy. So the choice of treatment either is use 3 or more shots a day, or you use, so this called as MDI, multiple day injection. So multiple dose injection or multiple day injection. So and along with that, insulin pump. And with when you do this intensive therapy, you must check the sugar 3-4 times a day. So there is, that's a frequent communication with healthcare physician must be there. So what's happening, sugar, how it is controlled, bring your sugar diary, what's aggressive, and very important, pay attention to food intake. You cannot just hog food and say anything what you want, but you have to pay attention. So the choice of treatment is essential. So there is conventional, and the conventional where we're using in the past, mixing up the two insulins and then split mix regime and then seeing what's happening, sugar never getting controlled properly. So you're getting it. So now the intensive regime is being used more and more with multiple doses of insulin and multiple giving day and allow or use an insulin pump. So this is there very important to understand. So how I already told you this. How is intensive therapy delivered? Yeah, it is delivered, with either it is basal bolus regime or it is insulin pump. And it's also called as continuous subcutaneous insulin infusion. So you are continuously giving subcutaneous insulin infusion with the help of the pump. So there are pumps which have got a CGM, that is a continuous. So they keep on monitoring the sugar and you can always adjust the insulin accordingly. Okay, so there is a basic calculation are done. What are these calculations to find out, what is the basal, what is the bolus? You can do that. And besides this, you have to take a total dose insulin. So once you have the total dose of insulin, you can then find an insulin sensitivity factor. How much insulin, regular or rapid, will bring down the sugar, that is there. So that's called insulin sensitivity factor. So you whatever your dose, the total dose in a day, you take 1800 and some in the when you're using a regular rapid X, you take 1500 divided by total dose. That will give you the amount of insulin which you bring down the sugar by 40, 50, whatever the value comes. That's insulin sensitive. Then there's insulin carb ratio. So number of grams of carb which for 1 unit of insulin required. So here you have 500 upon total daily. So I think adults it is like this, but in the pediatric age it will be different. So we're coming to the next slide where you use a different. So therefore, this carb ratio can be used even in injection. So when you're giving MDI, also when you're giving analog, you can use the same carb ratio to find. So how much carb you're taking, this much insulin you have to take. Okay. So what's most important is total dose insulin requirement. So in the last 1 day or this thing, how much dose insulin required, and then you say, that means this is your total dose required. The 500 divided by total dose insulin requirement, that will be your amount of the insulin carb ratio. Now, insulin carb ratio will be slightly different in the younger age. Now, if the patient is around under 5 years, most of the time he'll be taking carbs, milk mein carbs, other khana khaya carbs, cereal khaya carbs, everything is carbs, basically. There are very few protein diet and very few fatty business. So therefore, his breakfast, his will be different. So the where you have used 500 upon TTD, here you will use 150 in the breakfast upon the total insulin dose. So you can see here that it will be the whole thing picture scenario will change. So if you're having a total insulin dose, like 10, and this is 150, so you need is 1:15 only. So if it is 500, then it becomes 1 is this one. So therefore, you need more boluses in smaller children as compared to the adult for bringing down the sugar. So therefore, in the midday meal, 250 by the total dose, and in the evening meal, 250. Now, as a child grows older, 5 to 10 years, you can use a different. You may use 300 upon the total dose or 250 upon total dose. And as the child goes older, over 12 years, their different become different. 350 upon total dose or 300 upon breakfast. So you can see that in the breakfast, the sugars are always higher in children as compared to the adults. So therefore, you are having a different, ratio, the insulin carb ratio as compared to the lunch and the dinner. Okay, there's something which very, very important message that you have to have a different carb ratio. So you need to have, you cannot use a common this thing, because breakfast, all his kids have more higher sugar as compared to the younger, the adults. Now, so these are better number for pediatric population to have the carb ratio, right? So maybe, in a child of, I would, if a child is 3 years old, I would use this, 1 to 50 instead of using it. So total 150 divided total daily dose. And so if I have a total daily dose is 10, so I will use a 110. That means I need for every 15 carbs, I need 1 unit. Whereas if I had used the formula 500 divided by 10, it would be 50. So every 50 carbs I need 1 unit. The sugar will never come to control. That's what's happening. So using a different instant carb ratio is very, very important. And when it comes to the, younger children like 0 to 5 or even 5 to 10. I hope that makes a lot of sense to what I'm saying. So let's take an example. 20 grams, 20 kg of a child, 20 kg of a child, who is on 24 units. So let's take 24 units per day. Insulin is part, 5 units breakfast, 5 units lunch, 3 units for dinner, large 11 units of it. So he's taking around, total 24 units. His pre-dinner blood glucose is 280. The insulin sensitive factor, we have taken the first one, the 1800 and 501. We could have also taken the 301 in this case, because just 20 kg will charge. So 20 kg means he may not be more than 5 to 6 years of age. Okay, so therefore, the insulin sensitive factor is 1800. This is just an example. 1800 divided by 24 is 75. Insulin carb ratio is 500 divided by 24 is 20. So this much carbs, 20 carbs, you need 1 unit insulin. To bring down 75 grams of sugars down, you need 1 unit of insulin. Okay, so he takes 60 grams of carbs. So 60 grams of carb he's going to take. So total target blood glucose is we're keeping as 130. His pre-dinner is 280, pre keeping is 130. So the extra glucose is 280 minus 130 is 150. Okay. Now for the carb ratio is 20. So 60 gram means that he needs 3 units. So 60 divided 20 is around 3. So 3 units he needs for the food he's going to eat, and he needs something for the correction, which is 150. So that is 75 insulin ratio. 75 1 by 2. So 2. So 3 plus 2, 5 units. So he needs 5 units at the dinner time to bring his sugars back to normal. Okay, so this is how you do it. That's how you do it. Now, then coming on to insulin pump. I hope people have understood this. This example I gave us that to make you people understand whether you use an MDI or whether you use a pump, you have to do insulin sensitive factor. You have to insulin carb ratio. Then once you have done this, then you have in your front of you that this much insulin is required for this much bringing out sugars, and this much is required for this much carb. So it becomes easier to do. Then you have a lot of exchange carbs. So if you're having a roti which is 15 carbs, and if you take another thing which is 15 carbs, you exchange it. So when you want to do need 1 unit for that, you need 1 unit. You may be having a pizza, a small piece of pizza which is 15 carbs. You can use that. Okay, so that's why therefore it's important to have insulin carb ratio. Insulin pump, that's the most important. The latest things now, most of the people want insulin pump because they feel it's the best way of working on. So continuous subcutaneous insulin infusion, most physiological method, need careful patient selection and intense education. Very, very important. The patient selection and intense education. Small inert cannula inserted subcutaneously. Multiple doses. You need very, very, you need this, the rapid acting ultra short acting insulin inside the pen pump. And then you will get the results better. Because we want to be more physiological, as more physiological possible to our pancreas. That's why we do. So patients should be advised to rotate cannula site every 3 days, not to be more than 3 days, because then the sugars come higher than the patient come. They're using the cannula site for 6 days, and this is the sugar is very high, the pump is not working properly. Then when you go back, gadget history, I have not changed it for the last 5, 6 days. So that's why it's very important. Changing of the site is very important. Same way like in any other giving injection, there's a small, there's a device, this insertion like a cannula which goes inside. So being a foreign body, it may be causing a reaction. So after 3 days, maybe that area does not work and it's not giving. So the other side is that you may get a malfunction, so maybe chance of DKB is becoming less and less because of the education, people being taught about the pump more and more these days. Now the only thing is you do more frequent blood sugar check. So therefore now a lot of people are using CMS, they're using sensors, so they don't need to prick their fingers again and again. They can just do with the device. which we'll talk maybe some other day about CGMS. And therefore, with the help of that, you don't need to prick again and again your fingers to find a sugar. You can just do that. And then you can accordingly, you can, program the pump. So education is the most important thing. And I think, this is not a flip side now, because a lot of kids, I've got a lot of patients on pump, and I've seen boys and girls with 10 years, 8 years. They know much more about these things than the parents can understand. So this he will come and he will operate the whole pump in front of you and show you that, okay, this is what I did, this is what I did, this is what I said, these are the bolus I said, I changed this to this thing, I did this and this. Because they know so much about IT, this, their kids are now 4 or 5 years are playing with mobiles and playing with gadgets and all. So it makes a difference. The only thing is, I think personally, the main factor is cost. It's expensive, we do not get it under insurance cover till yet. There are some places where, like in ESI and in CJS, I think they've started now where they're giving it, and many corporates they have started giving on and the insurance like for pumps are being covered type of. But that's the main factor. Is I think that's the main reason why less people are still on pump because of the cost. So little bit just a line about the medical nutrition therapy, and there's nothing like diabetic diet. Please understand this. All type 1 diabetics, there is nothing like diabetic diet. So we have to stop this concept. Tell people normal diet, balance, normal balanced diet. Enough of protein, enough of carb, enough of fat. Everything should have. So healthy eating principle, balance the food insulin. Two all eating is not. There's no need for snacking when you're using this basal bolus or pumps. So remember that. So two alling is not required. Mid-stream snacks not at all required. And most important is prevention of obesity. People are eating, taking insulin, and there. So we want to prevent obesity. And small amount of sugar may be permitted as a part of meals with care to keep this in suggested limits. So gluten's limit to keep it. And once in a while, treat can be given, to obtain long term. So if you do that, the child will definitely cooperate with that. He's also been able to give a chance to eat whatever he wants to eat, as he's been able to have a treat. And you adjust the doses of insulin according to whether using an injection, whether using a pump, and then according to that. So that's why very, very important. So that's why the management, all these things, the family is a very important part of it. So the key point to take home is personalize the insulin regimes as per individual need and the daily routine. So you have to personalize all the patients and regime according to his resources, according to his understanding of the thing, according to family, how the family set up and family mind, how they're accepting of him. And that's why, therefore, and per individual need, maybe there is someone, boy, a girl who's studying a lot in the night and they need different. So therefore, you have to, according to the individual need and daily routine. So thank you very much for your patient listening.